Hi, everybody. It's 7 p.m. in Paris, 1 p.m. In New York, and it's my great pleasure to welcome you all to this new broadcast of the IACH Journal Club, the Journal Club of the International Academy for Clinical Hematology. I think you are all becoming more and more familiar with the Journal Club, which is supported by an unrestricted educational grant from Takeda Oncology. And for today's Journal Club, we have chosen the Scientific Steering Committee of the IACH has chosen the article by Dr. Khan and colleague entitled Fecal Microbiota Diversity Disruption and Clinical Outcomes After Autologous Hematopoietic Cell Transplantation, a multi-center observational study. So you can see the summary of the study here. This is the abstract, and it's quite an amazing study conducted in 534 adult patients who received an auto transplant for myeloma or lymphoma. And actually, the investigators have analyzed actually the microbiota and the impact of the high-dose chemotherapy, but also the impact of the diversity on the final outcome. And the key findings from this paper, in my opinion, are summarized on these figures, highlighting the disruption of the diversity over time and the change in diversity between the comparing healthy controls, but also before and after transplant. But also the most striking finding is about actually the impact of the diversity on patient outcome, whether progression-free survival or overall survival. So these data are really very important because it is showing that the diversity of the microbiota is likely to have an impact on the final outcome of the patient. And to discuss all of these findings, it is my great pleasure to welcome Dr. Jonathan Peled, who is the senior author, actually, of this blood paper, and who kindly accepted to participate into this journal club. And we have also, as a panelist, Dr. Florent Malard, from Paris, who is also an expert in the field of microbiota and stem cell transplantation. And I believe Florent and Jonathan, they know each other very well because obviously Florent did his postdoc at the Memorial Sloan Kettering, where Jonathan is based. So good morning or good evening, gentlemen, and welcome. We're very happy having you with us.
Thank you very much. It's a pleasure to be here and good to see you,
Okay.
Dr. Malard and Dr. Mohty.
So let's start the discussion, and I'll give the first word to Dr. Malard, where I'd like Florent to know what was your initial thought, or whatever you thought about this paper when it was published and you read it. What was your immediate reaction?
I think it was really a great study because we have a lot of data regarding the setting of allogeneic stem cell transplantations on patient outcomes. And of course, in the setting of allogeneic stem cell transplantation, this is mainly an impact of microbiota on complications, on transplant-related mortality, in particular graft-versus-host disease. In the setting of autologous stem cell transplantations, non-relapse mortality is very low, about 3%. So really, we do not expect to have a very strong impact of microbiota on patients' outcome. And in fact, at the end, we have an impact not only on progression-free survival, but also on overall survival. So it was really some amazing data with a huge number of patients, included both lymphoma and myeloma patients, to be able to demonstrate that microbiota was also important in the setting of autologous stem cell transplantations, and that may suggest that autologous stem cell transplantation is not only high-dose chemotherapy, but probably the role of the immune system and of the microbiota is important in the long-term control of the disease after transplantation. So really, I want to thank Sony for performing this very important study.
So yeah, thank you, Florent. So Jonathan, can you give us what are the key findings and what was the rationale behind this work? I mean, you have really performed a very large study, more than 500 cases, more than 1,100 samples being tested. So a huge effort. So what was the background and what was the question and what was your hypothesis to go in this direction?
Well, first, thank you very much for having me and for the question. You know, I think one aspect here that's worth mentioning is the value of biobanking on a routine basis at an academic or a non-academic medical center where you have transplant patients whose clinical outcomes are universally collected anyhow. And so there's a tremendous value to prospective weekly biobanking of samples, either blood or stool in this case. So that's just a brief comment about not even hypothesis-driven research, but just in general generating resources to go in and tap later. And that was part of the vein in which we initially started the biobanking. But that being said, I mean, Florent, you mentioned that there's a link between gut microbiome and GVHD, which is true, but there are a lot of important outcomes that both auto and allo patients are susceptible to, namely infections and also organ toxicities, even short of mortality itself, which we hypothesized the microbiome might be contributing to. I think we're all familiar, those of us in clinical practice, with the effects of melphalan on the gut and diarrhea and our patients' long-term problems with taste disturbances and mucositis and nutritional deficiencies. So from that perspective, it wasn't a big jump to speculate that the gut microbiome might somehow be modulating patients' experience during bone marrow transplantation. And then there's another element, which is what you alluded to, which is that there are some data out there that the control of disease after auto transplantation is not simply purely a result of the conditioning chemotherapy, but that there may in fact be some sort of a resetting of the immune system, if you will, that comes with the auto transplant, and that there is some modicum of immune control. So those were our broad hypotheses going into this when we set out to collect fecal samples from auto transplant patients.
But can I mean, we are trying to draw a comparison between allo transplant and auto transplant, and obviously they share some common issues. However, usually one reason we've been always advocating about the dysbiosis that we can see in the setting of allo transplant is in relation with the numerous antibiotics, febrile episodes in these leukemia patients, but also many chemotherapy regimens that were given before the allo transplant. It looks to me that in an auto setting, at least in myeloma, we have less use of antibiotics, and patients are not receiving the conventional chemotherapy. They are receiving proteasome inhibitors, IMiDs, dexamethasone. So I was a bit surprised actually with the level of disruption and the low diversity in some patients. Any explanation, any clue about this?
I mean, that's a great question, Professor Mohty. I think that the prior exposures that patients get are probably what's driving this, more so than the mere presence of a disease, of a malignant disease directly affecting the gut microbiome. But let's not forget that even though patients getting a myeloma therapy as outpatients might not be admitted to the hospital for fever and neutropenia, they're still kind of miserable in the sense of their nutrition is not ideal. They still get diarrhea type side effects. And so I think there is still a treatment burden, and we still see that those patients are different from normal. And with respect to the lymphoma patients, I think that's also probably the multiple cycles of treatment that a lymphoma patient might get before they come to transplant is probably also a major driver here.
Florent, what do you think was the contribution of the high-dose chemotherapy on the diversity? Because this is well established for large spectrum antibiotics. However, how can we quantify the impact of high-dose chemotherapy, whether melphalan 200, as in the case of myeloma, or beam, you usually use in lymphoma? Any thoughts on this?
For sure, high-dose melphalan contribute to dysbiosis. There is several facts. We know that high-dose melphalan is associated with gut toxicity to diarrhea, and in the blood paper, there is also some data when they look, I think, to the correlations between the gut microbiota compositions and the stool compositions, and they find that there was a correlations when there is some non-diarrhea stools. The microbiota composition was different compared to the stool with diarrhea, which directly suggests that high-dose melphalan contribute to this diarrhea and to the gut dysbiosis. And the second fact in that with high-dose melphalan, there is some patients where we don't use antibiotics and we use less antibiotics compared to lymphoma patients and also to allogeneic transplantation. So I think that high-dose melphalan is a very important driver of gut microbiota dysbiosis.
Jonathan, do you agree?
I agree with that, and I think that one clinic. I mean, you asked me earlier a question which I haven't answered, which is what are some of the key take homes? But I'll pick up on what you just said. You said, Dr. Malard, that when we give our patients these very gut toxic drugs, I think we should be mindful of the damage that we're doing to the microbiome, and take that into account as we design antibiotic drugs for them. For example, Ying Tower at our center has shown in a pair of papers in Clinical Infectious Diseases that when you have domination events with certain organisms in the gut community, that dramatically increases the risk of a bloodstream infection with the same organism. So even before you get to outcomes like overall survival and so on, just the idea of preventing a bloodstream infection in our patients could perhaps be approached by strategies to mitigate microbiome damage. And I think that patients who are given very gut toxic conditioning regimens, for example, melphalan containing regimens, are a perfect population in which to pilot therapeutic interventions.
Okay, thank you, guys. So assuming today that I don't believe, I mean, at least in the myeloma field, I know that melphalan is here to stay, and we will have to live with the role of auto in multiple myeloma. Things may change in 5, 6, or 7 or 10 years, but still today we know that there is a clear progression-free survival advantage. There is even over the long term, at least based on the European Myeloma Network studies, an overall survival advantage. So with this in mind, and we continue these auto transplant in myeloma, for instance, Florent, what kind of interventions do you envision to improve actually the outcome of these patients? And actually, my question is about how can we allow these patients to recover or to increase their diversity, have a richer, I would say, microbiota, because apparently this is going to translate into a better outcome. I think someone alluded to the nutrition. I don't know what kind of, you know, active interventions you can do with nutrition. What do you envision, Florent?
So there is two different things. I think this is not the same thing from the high-dose melphalan on myeloma and from lymphoma patients. So if you want to focus on high-dose melphalan, as we already said, a high-dose melphalan directly contribute to gut microbiota dysbiosis. So we can think to use antibiotics differently, maybe for patients when you have some fever, but you don't find the pathogens, you can stop the antibiotics after 7 days until instead of keeping the antibiotics until neutrophil recovery to decrease the impact of the microbiota. You can also think to avoid piptazo or imipenem antibiotics, but at the end you will still have the effect of high-dose melphalan on gut microbiota dysbiosis. So it may improve in part, but it will not be enough. So we have to think about something else. So of course there may be the use of probiotics. Maybe you can increase some kind of beneficial bacteria, but here we don't have yet a lot of data to know what are the good bacteria and what are the bad bacteria. In the paper they look at the bacteria composition, they find that Enterococcus may be associated with an impaired outcome, but we don't find any bacteria that were really associated with an improved outcome. It is not the same thing as in the allo setting when we know that the butyrate producing bacteria are really associated with an improved outcome. So which kind of probiotic we are going to use, we are not sure also what we have to target. So maybe what we are already doing currently, this is the use of fecal microbiota transplantations after autologous transplantation, after neutropenic recovery, to restore the bacteria back to normal. So we can use either some autologous, we collect the feces from the patients before the transplantations, we assess that the diversity is good, we frozen them and we give them back to the patients after, or we can use some third-party donors. So I think it is probably the more promising strategy, or at least the strategy that we can set up the more quickly for our patients.
Jonathan, are you in line?
I'm certainly in line with the categorization that Florent articulated. I think that FMT, fecal microbiota transplantation, FMT, is immediately available. There are programs ongoing in this, and one need not discover the key organism or the key metabolite to package into a pill. That's sort of the advantage of it. You know, I think there's an interesting parallel that I'll point out for the interested members, I think, on this call, that there's sort of a parallel between transplantation of bone marrow and feces, I think, where our field began with just aspirating whatever's in the pelvis, in the marrow, and give it to the patient. And that, I mean, although we still do that, we did that long before we knew about the existence of innate lymphoid cells and the existence of alpha beta versus gamma delta T cells and so on and so forth. So that there's a precedent for just doing the transplant, even if you're not sure what's the active principle in the transplant. Is it the bacterium? Is it soluble factors? Which bacteria is it? Is it spore formers? Does it matter how diverse it is? Does it matter what features of the donor are the key ones? And over the decades of doing this, we'll position ourselves. Hopefully, it won't take decades to position ourselves to understand more and more about what's in these grafts of feces, if you will.
So based on this, Jonathan, and in your studies, we have a question from the audience. Actually, we have plenty of questions. Unfortunately, I can't take all of them, but I think many of what has been said answers these questions. So can we predict actually the microbiota damage? I mean, the level of the damage. So that may allow to have a sort of a personalized or tailored approach.
That's a great question. right now, most microbiome and analytical approaches require several weeks of deep sequencing. There are efforts to develop rapid turnaround microbiome profiling methods at the point of care. These include things like panels of quantitative PCR probes for key organisms. These include biomarkers such as urine concentration of indoxyl sulfate, which our colleague Ernst Haller in Regensburg has developed or is developing into a biomarker that measures a metabolite that's produced by healthy members of a commensal community and that's concentrated in the urine and is then measurable by mass spec. People are also looking at plasma metabolomic profiling as another approach to a rapid turnaround assay that can give you a profile of what a patient's gut might be doing at a particular time in ways that don't require next generation sequencing. So I think that these sort of approaches are very interesting, and I think that they'll be coming. I think there will be a time soon where clinicians at the bedside will be able to order a profiling test of a fecal sample.
Okay, so let's move now. Sorry.
I was going to make a quip about how we have to be careful about quackery in this field, and we just saw in the last couple of weeks one company in the United States, Ubiome, which purported to offer such a service, that is now under criminal prosecution for lying to investors about their abilities to provide reliable information to clinicians. So we have to be careful to separate carefully done biomarker science from from quacks.
So let me move now to the outcome story, Florent. So when I look to the myeloma patient, they receive an induction VRD, DARA VRD, DARA VTD, and the number of cycles can be variable. They receive an auto transplant. They would receive consolidation and maintenance therapy for many years. And actually, one of the dogma in multiple myeloma, for instance, that it is roughly almost very difficult to show an overall survival advantage, because at time of relapse, these patients are going to receive a salvage therapy. And at the end of the day, the overall survival is going to be roughly the same. But here, I think just based on one criteria, which is the diversity, we see an overall survival difference. This is really a very powerful tool if it is confirmed. What are your speculations how to explain this advantage?
So yeah, this is a very interesting question. I have one comment on one answer. One comment is that maybe also there is some patients that will have received more induction chemotherapy before the auto transplants because there are some high-risk myeloma. So before the auto transplants, they already have an impaired microbiota. And in fact, the impaired microbiota is just a surrogate marker of the aggressivity of the myeloma, and that may explain at the end the lower overall survival in those patients. So, but I don't think it's explain all the stories. And what I really think is that there is an effect of the microbiota on the immune functions of the autologous stem cell transplantations. And in fact, there is some data in myeloma, in mice models, that show that microbiota contributes to multiple myeloma disease in the pathophysiology of multiple myeloma. So we know that microbiota can drive progression from to multiple myeloma. And there is also another study that also involves the memorial on Dr. Peled that show that there is a link between the microbiota and minimal residual disease achievement. So there is really also some very important data that demonstrate that there is a link between microbiota and disease response. But my suggestion is that some improved microbiota will drive an improved or is associated with an immune system that is in good shape and that contribute to the long-term control of multiple myeloma.
So that means, Jonathan, that probably we have some good and bad guys, although we didn't identify them, that are going to play a role at the interface or to interact with the immune system to favor immune-mediated disease control or immune tolerance. Is this?
I think that's an excellent. That's a very well articulated hypothesis that comes out of these data. You know, and it's not only immune control of tumors in the post-auto setting that are receiving attention in this regard. There's been a lot of studies recently in the solid tumor populations in checkpoint blockade, where similar associations between the gut microbiome health and in those cases also in mouse models, there are data that suggest that modulating the gut microbiome can improve clinical outcomes. And recently, 2 papers in Science just a few weeks ago in melanoma patients have shown that a fecal microbiota transplant can render patients who've become resistant to PD-1 blockade suddenly now responsive to it. So I think that we have a lot to learn about how to modulate anti-tumor immune responses using the microbiome. I'll just add one comment, if I may. The question about an association between microbiome injury and number of lines of prior therapy is a very important one. Buried in the supplemental of this paper is a panel that I would invite the listeners of the webinar to peruse, which plots the fecal alpha diversity according to the number of lines of prior therapy. And I was kind of surprised that it's sort of flat across between 1, 2, 3, and 4 lines of therapy. There wasn't a clear trend.
So can I ask you, in line with this, we have a question from the audience, Dr. Lovell. Do we know the effect of dexamethasone on the gut microbiota? Because we know the myeloma patients receive tons of dexamethasone in every single regimen. Is there any information about this?
That's a great question. I'm not familiar with the effect of dexamethasone on the gut microbiome. However, there was recently a beautiful Cell paper from a lab, I think Dania is the last name, at Princeton, that looked at the effect of the microbiome on metabolism of steroids, and there's a deep connection there. So that's an area of future study.
Well, obviously, I mean, it's very difficult because all your patients receive dexamethasone, so you can't compare. But this is definitely very interesting. So we're reaching the last part of this journal club, Florent, and then I'll ask the same question to Jonathan. If you have today, you have really a very strong background to try to modulate the microbiota in these patients, let's say myeloma patients, because they are the majority today receiving auto transplant. The number of auto in lymphoma is decreasing thanks to the advent of CAR T cells. Actually, that's good news for our patients. So what would be the ideal clinical trial you would like to run in this setting to build upon, Jonathan results?
So yeah, I will think that I am in the best role. I can do anything I want. So in this
absolutely.
case, I will assess gut microbiota diversity before the auto. If the patient have a good microbiota diversity, okay, I go to the auto. If the microbiota diversity is impaired with some very quick results, I will perform first FMT with the third-party donors to restore gut microbiota diversity before autologous stem cell transplantations. And maybe it could allow us to decrease the risk of infectious complications during the transplants. And after the autologous after neutrophil recovery, I will repeat in every patient the FMT to restore the microbiota diversity back to normal. So after, what it would be great if it would be able to assess if it was effective treatment 1 month after, if we have a good restorations of gut microbiota diversity, or if we have to repeat the FMT.
Okay, so Jonathan, assuming you agree with Florent and you want to run same trial. But what's puzzling for me that we spoke about FMT, but FMT is not a drug. So what kind of material, what is the substance, you know, how are we going to prepare this drug? Because I mean, if you're going to treat patient or do randomization, you can't simply rely on something you do on the bench. Am I correct?
Yeah, I think that's a great point. I mean, I love your clinical trial design, Florent. I would say in my fantasy world, in our shared fantasy world, let me just tweak it and say instead of an FMT, let's rationally design a probiotic that has, I don't know, a dozen or so strains that we identify in the fecal samples of patients who do extremely well. And that we've identified that they can engraft well in a patient when given orally. And so if we had this magical pill, perhaps we could confer the benefit of FMT without the theoretical risk of transmitting infectious organisms, and in a way that was, you know, scalable. We wouldn't have to keep harvesting more poop samples from willing donors.
So if it is a magic pill, I guess it needs to be reproducible. So it needs to be comparable, you know, from batch to batch.
That's right.
So any thoughts how to achieve this?
Well, I think one approach to this that we're doing, we meaning the field broadly, not me personally, is culture collections from patient samples. So that would be, instead of just taking the stool and extracting the bulk DNA from bacteria and sequencing it, plating colonies on a variety of different rich media under anaerobic conditions, and then collecting a few hundred colonies from patient samples, which can then be individually sequenced and characterized, but also picked and expanded under good manufacturing practice conditions, under super aseptic conditions, in a way that's reproducible and scalable and reportable to the regulatory agencies and all the things that are required to make an actual drug. I mean, I think the microbiome field is just in its infancy, transitioning toward that type of technology.
Wow, that's fantastic. Florent, any last take-home message to our audience?
So I really find all this data very exciting. I really think that this is a future, and that we will design some complete therapeutic strategy that will associate autologous FMT or another next generation's cell therapy or immunotherapy that will be combined with some gut microbiota compositions combo, on that it will be some very basic treatments, maybe in 10 years, I hope.
Well, this is really fantastic, gentlemen. You've been absolutely, both of you have been great. Jonathan, again, congratulations for this lovely blood paper. And I think we all share the enthusiasm and the excitement about the role of the microbiota to allow our patient to improve the outcome of patients with hematologic diseases, but also cancer in general. That reminds me that 30 years ago, the backbone of therapy was conventional chemotherapy. 20 years ago, 15 years ago, we started having the targeted therapies, small molecules rationally designed. More recently, we had the cellular therapies with CAR T cells, but also maybe NK CARs and other cellular therapies. But it looks like that now we are opening a brighter future, having a fourth pillar of the treatment, which is about modulation of the microbiota. So thank you all again for joining the IACH Journal Club. As usual, it was a pleasure having you with us. And wherever you are, as usual, my conclusion, please stay safe, and thank you, and see you soon. Thank you very much.
Thank you very much.
Thank you.